Dr. Mark Jentoft. He's neuropathology, and in Mark's career, because he's still a relatively young guy, he's probably seen the transition of the role of the neuropathologist from being the person with the expensive microscope, making histologic diagnosis, to the person who's become really a geneticist to complement the microscopy techniques as well, and probably not so in the not so distant future, it may even complement immunophenotyping too. So I think it's really been a revolution in genetics, which has also influenced the revolution in molecular neuropathology. So he's going to update us on that field as well.
Thank you very much. So as mentioned, I started my training in 2006 as a resident, finished that in 2010, and then my neuropath fellowship in 2010 through 12. When we started, and I was a resident, I used to sign out with Dr. Scheitauer, and we could make the diagnosis of an anaplastic astrocytoma from an H&E slide and be done. And we would sometimes order stains on the cases. Many times we would, because he had interest in different things, but it wasn't always necessary, and it was much more of a rapid process. I enjoyed that. As June said, I've seen this transition, and when I started, I didn't have much of a molecular background. I didn't really want much of a molecular background, but it has helped significantly in our field to reduce uncertainty as far as what a diagnosis is, and make our diagnoses more congruent in between institutions. Before, if you showed a case that one person may call an oligodendroglioma at institution A to institution B, as Dr. Jenkins said, they might have a completely different diagnosis. So this has helped considerably, and it's also put science behind the modern diagnoses. So in 2016, as everybody I'm sure is aware of, there was a new WHO for central nervous system tumors. And as we can see here, it pretty much doubled the number of classifications of tumors. The actual tumor entities basically stayed the same. However, they incorporated genetic information into many of the diagnoses. About a quarter of these entities are glial neoplasms. And the WHO divides these into basic subtypes, and this is traditional off of their morphology. So this isn't necessarily taking molecular into account. You have diffuse astrocytic and oligodendroglial tumors, then what they call other astrocytic neoplasms. And the difference here is the other astrocytic neoplasms conceptually or morphologically are well circumscribed neoplasms. They have very little to no infiltration. So we're talking about things like pilocytic astrocytomas.